Constantly be curious about the world around you. The second that you lose interest in what it is you're doing and think, I don't have to think about doing this anymore because it's so easy or whatever, is the second that I think you do worse for somebody or you don't do as good a job as you could. Curiosity is what drives innovation. It's what drives us to be better, and I think it's what drives us to provide better care.
Hello, Dr. Fung. Thank you for being with us today and taking the time out of your busy schedule to come answer some questions.
Thanks for having me.
Can you tell us a little bit about yourself and your history in medicine?
Yeah, so I grew up in Manitoba,
Mm.
and um, it was great. Decided to go to university and didn't know what I wanted to do, and so I took everything I could. Uh, Thought I'd want to be a math teacher for a bit. Talked to my math teacher, and he said, "That's a really bad idea. Have you thought about medicine?" And I said, Not really, but I will now." And ended up going into medicine. Um, Thought I wanted to be a surgeon for a while, and similarly changed my mind. And here I am in radiology.
From radiology, when did you decide a subspecialty? What is your subspecialty?
Yeah, so radiology is it's a complex field. So we mirror most other, if you think of surgical specialties or internal medicine type specialties, so people think of, general surgery and orthopedic surgery and cardiac surgery and neurosurgery and all that, or neurology and rheumatology and gastroenterology, all those different specialties. Radiology is similar. It mirrors those types of specialties. And so for me, I'm a pretty general liking guy. I like everything. So I chose to do a specialty in what we call body imaging, which is essentially everything from the diaphragms down to your pelvis. Um, and because it's very general, it covers a lot of what we do. It covers a lot of emergency medicine. I get to do a lot of interventional work, so I get to talk to people regularly, which is really nice.
Mhm.
And so it was a big draw for me.
Can you explain a little bit more about what interventional medicine is?
Yeah, so if you've never met any of my colleagues in intervention, that means you're doing well, which is excellent. But what we do is a lot of what we do is dealing with um, diagnosing malignancy or treating conditions that involve your vessels. That's kind of the two sort of areas. So I'm the former. So a lot of solid organ biopsies. If you have a spot on your liver and you don't know what it is, and they need tissue to get that. Back in the day, they used to have to open you up and cut out that piece of liver and figure out what it is. Nowadays, we use ultrasound or CT or sometimes MRI to guide the needles that we use and prevent surgeries. And so I'm one of the people who finds those lesions on ultrasound or CT or whatever, puts a needle into it and takes a sample to tell the pathologists and the surgeons or the clinical team what's going on inside you.
Do you feel like that's rewarding for you?
Yeah, it's a lot of it's a challenge sometimes,
Mhm.
but it's a lot of fun being a big part of a patient's care
Mhm.
going forward from what is often a very difficult diagnosis. But uh, it is rewarding in that I think you move people into care pathway that otherwise they wouldn't be able to do so or to receive in time. So if you think about malignancies or cancers, if we're not there, often the disease has spread beyond the point of treatment. And so we try and intervene as early as possible nowadays with those. And so I think that in and of itself is rewarding because you're diverting the patient's course of their entire life into treatment and recovery.
Mhm. Yeah, very cool. How would you characterize your current contributions to the field of radiology? Loaded question. I'm sorry.
Yeah, I mean, I'm pretty busy. So clinically, we've talked about that a little bit, just the diagnostic and interventional work. But beyond that, one of the things that I really appreciate about working where I do is we have the ability to and the support to contribute beyond our clinical care. So I do a lot of education. I'm involved pretty heavily in the medical student education from just side by side apprenticeship style teaching to direct didactic lectures in the medical school. Obviously, with the residency and the fellowship programs we have here as well, I'm involved in those uh, teaching and support and mentorship, etc. Um, and outside of that, as I alluded to earlier, I do a bit of research, and so um, uh, we get to contribute to the specialty in terms of pushing it forward and pushing the boundaries of the specialty forward. One of the biggest things that I do with respect to just a global radiology community is I've been pretty heavily involved in guideline development, both nationally and internationally. And so what that is just trying to help our colleagues with all of the evidence that is out there, because medicine is moving forward faster and faster and faster, and people are publishing all sorts of different research in all sorts of different areas. And it's very difficult to keep track of what to do with any one thing that you find or anything that you see or anything that you do. What is the evidence behind that? How do you make those decisions? And so I find guideline development is very interesting and helpful for myself and for my colleagues. So in internationally, I've worked on gallbladder polyp recommendations. So what do you do when you find one of those? For surveillance screening for liver cancer, and then more locally, and locally I mean within Canada. Um, what do we do with other incidental findings? Because Canada in itself is a very different country than a lot of other medical systems, as people are becoming increasingly aware. A single payer system like ours, where we have the government paying for our health care, is a very different model than something like America, where there's a lot of private pay, or some places in Europe or Australia where there's a dual system. And so we have intrinsic challenges within this country and intrinsic opportunities within the country that are different. And so it's good to work internationally. It's good to see what other people do. But at the same time, we need to filter some of that literature and some of those recommendations to match what we can and what we do here in this country. And that might be different modalities. We do a little bit more ultrasound and a bit more CT than some other countries. Our procedures are often a little bit different just because of the access that we have. And we're going to talk a little bit about, I suspect, some of the research that we're able to do, because we can push the boundaries a little bit more in this country than we can in some other countries, just because of how systems are designed provincially.
Interesting. So why did you decide to do research on prostate cancer?
Prostate cancer has been an interest of mine for a while. Number one, it's highly prevalent, which means that a lot of the population has it. I tend to tell patients that if you're 70% of men are going to have prostate cancer. If you're 80% of men are going to have prostate cancer. This isn't like other types of cancer where if you get it, this is devastating. This is what is expected. And in fact, it's a badge of honor to even get it, because it means you've lived that long. So congratulations. But because it's so prevalent, we really want to catch it early, because it's not about, for most people, it's not about just stopping it. And it's not like other cancers where like it's going to spread everywhere and it's going to kill you. In the majority of cases, it's actually very low-grade disease. We're just trying to stop the spread of the metastases. We're trying to stop the pain that you get from actually having it. And if we can catch it early enough, we can do that. One of the things that really got me interested was there's a new technology that came out, micro-ultrasound. And micro-ultrasound, I've always had an affinity for ultrasound. I'm part of the Society of Radiologists in Ultrasound, which is like a big international organization of people who are very interested in ultrasound and making sure that we're doing what we can for a widely spread modality. And micro-ultrasound came out when I had just finished my fellowship, and it it uses ultra high frequency wavelengths to get very high resolution pictures of things that are very close to that probe. And what it allowed us to do for prostate was, because we're already doing transrectal ultrasound for prostates for biopsies, etc., we could get the probe right on the prostate, and you can actually see the little tubules within the prostate and the cancer that is forming in those tubules. And so we had sort of said, I bet you that this is as good as MRI is at picking up prostate cancer, and the standard of care right now is MRI. If you think you have prostate cancer, or your physician believes you have prostate cancer because your PSA is elevated, your prostate specific antigen is elevated, or they've done a digital rectal examination, they feel something kind of funny. The first step is generally either, it used to be biopsy, but as MRI came on board, it was MRI.
Hmm.
And I helped start the program here for prostate MRI because that was the thing. And then prostate ultrasound, micro-ultrasound came out. And MRI is wonderful, but the challenges for access in this country are evident. Everyone knows that it's very difficult to get MRIs. And so screening populations for MRI does not work very well. Ultrasound, however, you don't need a big magnet. You don't need to worry about pacemakers or metal or anything like that. When was your last surgery? None of that stuff applies. It's just an ultrasound machine. You can do it in an office. And so this has potential to dramatically expand access for prostate cancer screening in a country like ours where MRI access is not guaranteed. So that got me very interested. And thankfully at the time we hired a new urologist, Adam Kennard. He was a graduate of our program, went down to the States to train just like I did, and came back just as gung-ho as I was. And so between the two of us, we've worked really closely at changing how we look at prostate cancer for Albertans. He is a phenomenal researcher. I can't speak highly enough about him. And he managed to convince 19 other institutions on this planet, in 8 different countries, to do micro-ultrasound with us, do a randomized control trial, and take a look at comparing MRI and micro-ultrasound formally in terms of diagnosing prostate cancer. And is it actually as good as MRI? And that's what we found. We published that in JAMA last year. JAMA is for those who don't know, it's a huge journal. It's one of the biggest medical journals in the world. And it was actually, that paper was just awarded the paper of the year by the European Association of Urologists for the most impactful research in urology this last year, because it's changing the game. That paper says that micro-ultrasound is not inferior to MRI. You can do micro-ultrasound and diagnose prostate cancer just as well as you can with MRI.
You mentioned a little bit how the research was conducted, but can you dive into that a little bit more?
Yeah, so as I said, we were obviously the lead institution here in Edmonton, which is a pretty big deal. And it's really great to have that kind of, to be able to lead the world in something like that. But what Adam and I did, we started by number one, getting one of those machines, and then teaching ourselves how to use it. He had some experience in his fellowship down in the States where he had done this with his machine before. I had done fusion biopsies with ultrasound in my fellowship, but not with this specific machine. And so first we had to learn how to use it. What does prostate cancer even look like on this machine? And then once we were comfortable with that, we wanted to track our own results and make sure that, what we were seeing is in line with what we were seeing with the MRI fused biopsies. And so our initial biopsies looked at patients who had had an MRI, who we saw a lesion on, and could we target it with the micro-ultrasound? And we found that we were actually really good at that, which was great. And then we moved on to say, okay, well, what if we did it without the MRI? How are we doing then? How are our cancer detection rates then compared to somebody who has an MRI and gets a biopsy, or somebody who never had an MRI and just got a blind non-micro-ultrasound biopsy the way we used to 15, 20 years ago? And we found we were better than that last group, and we're equivalent to the MRI group. And then we said, okay, well, that's great if we're equivalent to the MRI group, but is that just us because we're really comfortable with it?
So we're really good.
Or is that everybody? And so then he phoned up his friends in urology all around the world, and he managed to convince a bunch of people to do it with us. That's kind of how it started.
Cool. And so what is the end goal? What is the implications of this research?
Yeah, so as I said, one of the biggest things is just improving MRI access or decreasing the need for MRI. So MRI is, I think, not going to go away. It's really important in planning for prostate cancer. We've got other tests in the horizon. PSMA PET is one area that we also lead the world in, actually, where we've published some new tracers and been successful in that, in finding that we can localize disease both in the prostate and outside of the prostate. So I think in the future, we're looking at differential use of different modalities than what we have in the past. Historically, it was just a finger in a biopsy or just a finger in surgery, and then MRI came on, so then it was MRI and a biopsy, and now micro-ultrasound, and so now it's maybe you get a micro-ultrasound if you can't get an MRI, or if you don't have access to an MRI, and then a biopsy. And then maybe in the future, we actually can use micro-ultrasound to surveil known cancers. So as I said, sometimes we don't treat prostate cancer, we just watch it to make sure it doesn't transform into a more aggressive type. Currently, we do that with MRI. We're looking at, can you do that with micro-ultrasound as well, so that they don't need to get annual MRIs. Patients can get off of that MRI train and allow other patients access to those machines. And we reserve those spaces for prostate for the cases where we're not sure on micro-ultrasound. Or, is there a future pathway where PSMA PET is used more commonly? So that if you've got somebody who's indeterminate or intermediate stage where we think they might be spreading, but it's not in the prostate, that does happen for a small percentage of cases, maybe we leverage PSMA PET a little bit more, and that fits into the pathway somewhere. And so we actually have ongoing research right now on that. We have research on how do we even follow patients or screen for patients with metastatic disease for prostate cancer, because the guidelines between the US/the world and Canada are actually different right now. So we're looking at that.
How are they different?
They differ in terms of what they recommend. So the international guidelines currently for certain subtypes of prostate cancer recommend a CT chest. Or sorry, do not recommend a CT chest. They just recommend an abdo-pelvis CT and a bone scan. The new release of the Canadian recommendations actually added on a CT chest. We're taking a look to see is that evidence-based or not, because it seems like not a lot. They're already getting a CT abdomen and pelvis, but number one, we're talking about radiation, and radiation has its own risks inherently, and two, depending on the model of the province, there may be funding implications. In other words, you may be able to use that CT chest to CT another person instead, if you don't do it. And so it depends on the province, obviously, with respect to that, but it's very important that every single test that you do is actually indicated and has evidence behind it. And it comes back to that whole guideline thing I was talking about earlier. Like, we need to make sure that decisions are being made on the best evidence available. And so even if we find that there is good evidence for it, that's okay. You have to that's research. You have to validate what you're doing. And so that's one of the things we're looking at right now, for example. And then with respect to those guidelines, neither of those actually currently talk about PSMA. And yet PSMA PET, which is a nuclear medicine test, excellent for prostate cancer, really good for localized disease, and more importantly for disease that is not in the prostate, if it's in the bones or the lymph nodes or anywhere else. PSMA PET is phenomenal for that. They aren't currently recommending the use of it, probably because of difficulties with access. However, in this province, we are one of the leaders for PSMA PET, I would say. We offer it here. There's private pay options for it. There's some, I believe, public access to it, depending. Obviously, that's a bit more restricted because it is a fairly expensive test. But I think in the future, molecular imaging or nuclear medicine is going to be huge with respect to this, and all oncology work. Prostate cancer is no exception.
The guidelines you talk about, these guidelines are to go to like family doctors, family physicians?
Some of them, yeah. So I work on the Canadian Association of Radiologists, a couple of their working groups, and I've chaired a couple of the appropriateness guidelines, and those appropriateness guidelines are designed for family physicians or primary care providers to help guide them through clinical vignettes. If you have a patient with a renal mass, what do you do? If you have a patient who you think might have colon cancer, what do you do? What is your first step in terms of imaging? Or if you have a patient with simple reflux at night, or you go on a bender or something, and is that normal or not? What do you do? We have these clinical vignettes to help primary care providers in terms of directing them towards the correct imaging across the country. And the people who made up these panels, they included a patient advocate, they included specialists who are not radiologists, and radiologists from across the country, just to get perspective and make sure that this would align with the majority of the provincial healthcare systems. So those recommendations are designed directly for primary care providers and or patients if they wanted to take a look at it. But the more specific guidelines, so I've done work on pancreatic cysts, I've done work on soft tissue masses, gallbladder polyps we talked about, liver cancer. Those are designed for the radiologist. And so it depends on which publication you're talking about, because we can do work for that narrow scope for just the radiologist, or for broader scope for everybody.
I feel like I talk to a lot of people who aren't in the field of medicine, and they're confused on how a doctor decides whether they need to go for medical imaging or not. So can you explain a little bit to that?
It's a difficult question to answer because every patient presentation is going to be different. And so it depends on what the clinical presentation is. And the clinical presentation and the history are going to dictate what you do next. If you go for endoscopy and you want to make sure they don't have stomach cancer or colon cancer, the patient will have a very different history and examination than somebody who has like liver cancer and or pancreatic cancer, and they present with vague sort of abdominal type symptoms. So the more vague the symptoms are, the more likely I think you are to go to some sort of imaging, try and figure out what's going on. And you can't forget that, you know, the whole purpose of medical training in large part is not just to memorize how to take histories and how to follow an algorithm and just get imaging or do this or do that. If medicine were so algorithmic, frankly, we would have been replaced by robots a long time ago. It's to develop that sense that, like, you know, Brooklyn, I've seen you for like 15 years. I've been your family doc, and like something's just not right. Like it feels like something's off about you today. And I think we need to take a look at that because there's something funny here. You know, that internal sense, that spidey sense that's tingling is what you actually get trained to do. And so medical imaging aligns really well with that. And I know that's hard for our clinical colleagues to write down on the requisitions for us for history, that something's just off. But anytime I see that, they get imaging, because like I know that doctor is worried about something.
Okay, that's all the questions I have for you. Thank you for coming and answering all my questions.